from theheart.org, Medscape Cardiology. This is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Professor and Chair of Medicine at Stanford University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, this is Bob Harrington from Stanford University, back for part 2 of the 2022 Year in Cardiology Review. I'm here with my good friend and colleague, Dr. Mike Gibson from Boston. Mike is an interventional cardiologist at the Beth Israel Deaconess. He's a professor of medicine at Harvard, and he's the CEO of the not-for-profit BAME Institute, an academic research institute. Mike, in the first part, we were talking about doing clinical trials in China and being able to answer questions more rapidly. In this session, what I'd like to do is run through a whole bunch of individual trials, agents, big questions, and with the underlying theme of, can we do things better? One of my favorite trials of the year, a thing that I've learned a lot listening to people like Jim Januzzi and Greg Fonarow, this notion of rapid escalation of guideline-directed medical therapy for heart failure. We were all taught, start your beta blocker, add your MRA, add your ARB or ACE inhibitor, blah, blah, blah. Takes months and months. Now there's a randomized trial that says people do better if you start it all at once.
Yeah, strong heart failure, largely in Russia, Africa. I'm an interventional cardiologist. I kind of think I'm an aggressive person, but then I get kind of hesitant, when all these heart failure doctors say, no, start them all at once. It kind of scares me, but that's what they're advocating. Get all those pillars started at once. They started 3 of those pillars, beta blockers, MRIs, angiotensin inhibitors at once, and they did better. But it required weekly visits to up-titrate over that next month. That gets back to execution, gets back to infrastructure. Great idea. Can you do it?
Yeah, and do you have the team structure to do
Right.
it? I mean, if we rely on the doctors to do it, I don't think it's going to get done. You have to have a structure that allows the doctor, if you will, to lead a team of diverse individuals with different types of backgrounds, to make those calls every week to say, hey, how's your blood pressure? How are you feeling? Let's go up on the dose.
But Bob, there's also a biology lesson here. The human body is pretty amazing. I mean, it has all these redundant pathways. If you block this, well, you increase this. Heart failure is a great example of that. You do better if you block multiple pathways with a low dose or starting dose than if you pick 2 pathways and go very high in the dosing. And that's something, we're going to see, I think, also over in the statin side of things.
Let's talk about the statins. The thing that's really got my attention this year is now the lipid experts are saying it's not going to be one drug therapy. You want to get people down to an LDL that's acceptable for their risk profile. You're going to need multiple drug therapy. And guess what? Let's start them quickly so that you're not slowly titrating people up. I was at a meeting this past weekend, and I don't know if you coined the phrase time is muscle, or you came out of the research group where time is muscle was phrased, but now they're saying time is plaque.
Yeah.
What do you think of that?
Oh, clearly lower is going to be better and longer is going to be better. And in my own family, my 2 sons both went to their primary care docs and said, I want to get on a statin in my 30s. And they argued and showed gave them all the data. They're both on statins now. So I want to have my LDL down around somewhere around that of a hunter-gatherer, and the problem is, as you say, it takes a lot of different shots on goals. Statins lower your LDL, but they increase your cholesterol absorption. That's why we have ezetimibe. It blocks that pathway, that escape pathway. Similar things with LDL receptors and the PCSK9 inhibitors. Yep. All these things come together kind of like the Tom Cruise line, you complete me. The other thing, though, Bob, that I learned a hard lesson. We were going to talk about incidental findings and calcium scoring. I ended up having a calcium score of 1100. And it was a real wake-up call, because then with an LDL of 70 and an HDL about the same, how in the world did this happen? Well, we then looked and my Lp(a) was 2.75 times higher than normal. I would not have known that I was a skeptic about calcium scores, but I would not have known that had I had that test done. Now I'm searching for ways to get my LP little a down. And I think now that we fought the LDL battle, I think the next battle is going to be on some of these other markers like LP little a.
Yeah, I agree with you. There's a lot of data about LP little a in some ways being the silent risk factor because people aren't measuring it routinely. We don't have a great way to treat it right now, but there are trials going on
Right.
which will look at lowering LP little a and to see, number one, can you do it biologically safely and effectively? And number two, is that associated with improved clinical outcomes above and beyond statins? I absolutely agree with you. The other thing that's caught my attention this past year is, we all are using the risk equations, right? The pooled risk equations. We have it built into our electronic health records, et cetera. But, your sons are a great example. Do they have to wait till they're 60 before
No,
their score goes up? Well, that's just been 30 more years of plaque deposition. Why not think about the accumulated lifetime risk? And that's what people, I think, are starting to talk about.
but it's more than just cholesterol years where you multiply your LDL time your years. My LDL is really bad. My LDL is different than your LDL because I have an APO, because I have an LP little a and reality. Yep. So what I'm doing now for my kids is they're all going to get tested to see, if they have the genetic variant as well. About 20% of people are walking around with it. They don't know it. And they have a risk factor that's not modifiable by diet. We keep telling them to do diet. Well, it's not modifiable by that. It's not modifiable by statins or exercise. So I think we're going to learn a lot more about some of these other determinants. And I do think getting this treated earlier is better.
Mike, a couple of trials that caught my attention: furosemide versus torsemide, and then hydrochlorothiazide versus chlorothalidone. I think there's some good lessons there that here's drugs we've used for decades. Certain assumptions have been made. But to your point, you don't really know unless you test them. So for example, people thought, well, maybe torsemide is a better diuretic when you're acutely congested with heart failure. And maybe hydrochlorothiazide is as good as chlorothalidone, even though the trials largely used chlorothalidone. But now we actually have clinical trials data.
So much for experts, it really is important because, this was recommended in the guidelines. Chlorothalidone was recommended over hydrochlorothiazide in the guidelines. Well, you put it to the test and another great hypothesis, falls. So that's why we do trials. These two studies are exactly why we do trials, and we're better for having done them.
Yeah, I agree with you. And then the hydrochlorothiazide chlorothalidone trial, I love because of the way that it was done within the VA system and really sort of in a pragmatic design. And kudos to our colleagues at the VA for being able to pull that off. And kudos to our colleagues in the Heart Failure Network for pulling off the furosemide. Again, to your earlier point, Mike, networks, organization, execution. Here was two, a health system, the VA, a heart failure research group answered the questions.
Well, the randomized trial may be one of the most important therapies we have.
Yeah, well, clearly remains one of the most important advances in medical science.
Yeah.
The other thing that people love are supplements, Mike. I don't want to take a statin. I'm worried about those muscle things, but I'll take my various supplements. Well, we had a trial that tested statins against a bunch of supplements. Guess which one won?
Yeah, about $270 billion a year people are spending in the nutraceutical industry. And just because, they think it's organic and it's going to be better, turns out when you compare a statin like rosuvastatin at a low dose versus things like fish oil, cinnamon, garlic, turmeric, plant sterols, red yeast, rice, 6 different kind of natural therapies, no surprise, the LDL lowering with the rosuvastatin was, 30% better. And it's a drug that's costing $5 a month. And, I would hazard to guess it may be just as inexpensive, maybe less expensive than all those supplements.
Yeah.
So I hope we can get the message out about the nutraceutical industry.
Yeah, it needs to be exposed to the same rigor that many of the other things that people are taking for their health. When you said one supplement after another fell by the wayside, as you know, I'm a big baseball fan. It reminded me of the 99 All-Star game in Fenway Park, where the great Pedro Martinez stood up and just mowed down, boom, 1, boom, 2, 3, 4, strikes out the 4 best hitters in the National League consecutively. Maybe Pedro and rosuvastatin have something in common.
Maybe they do.
Mike, couple more things. Where in the area that you and I have spent much of the last 30 years working on, which is antithrombotic therapy. Boy, just when you think you have this figured out, dual antiplatelet therapy, single antiplatelet therapy,
Yeah, crazy world, isn't it? When we, you and I went through this journey of, we were putting people on 1 million drugs when we put a stent in, including Coumadin, and then we breathed a sigh of relief when ticlopidine came along because we could sleep through the night. Aspirin plus ticlopidine seemed to allow people to not clot their stent off.
Until their TTP.
Until their TTP, yeah, there was a little issue there. But then clopidogrel came along, more potent antiplatelets came along. Then we thought, yeah, we need this for a year. Well, turns out, no, we may not need it for a year. And we've been backing down 6 months, 3 months, 1 month, drop aspirin at hospital discharge. So, I call it, there's NNT, NNH, I call it NNB, number needed to blame. Interventional cardiologists, docs don't want to get blamed for bleeding. And, it's going to be safer if you drop the aspirin, that's going to be safer. No surprise. Question has been, is it going to be just as effective? And a lot of the data is suggesting it is as effective to drop it early. The other thing we got to realize is, your platelets calm down. They're pretty angry at the time of the ACS, but, they're going to get more and more quiescent over that year. And we may need to match the dose or the intensity of what we're doing with the underlying disease. Finally, the next big issue is we've given aspirin for, 50 years, but maybe thienopyridines are better than aspirin. And, certainly back in the 90s, we saw, in some of those initial studies that, aspirin was better, or clopidogrel was better than aspirin. So we've now seen some more trials that suggest this. We're now seeing meta-analyses that seem to suggest that a thienopyridine may be better for the long term than aspirin monotherapy. You're now going to see some comparisons of clopidogrel and ticagrelor, which one's going to be the better monotherapy there, building upon some of your Plato trial data. So yes, things are changing. On the other hand, there are also better aspirins now. There's a new aspirin that is phospholipid coated, so it doesn't damage the stomach as much. You see lower rates of ulcers and erosions. So, we just see newer therapies coming along. It's this kind of, what we do is we assess all the new therapies and evolve. And it's just amazing to see the journey we've been on.
Yeah, and I like how you say it, that over time things change, right? I always think about it as when I'm making my antithrombotic decisions, there's the patient and their characteristics that include their risk of thrombotic events and their risk of bleeding. Then there's their coronary anatomy, and whether it's diffuse disease, isolated disease, multivessel, single vessel. And then there's what we do to them. Oh, I put in a single stent in the mid-right that was a 4.0 stent that I post-dilated, to 4.25, and they have no other disease. Well, that's very different than I just put in, 25 millimeters of stent in both the LAD and the right. And oh, by the way, they have diffuse non-obstructive disease in the circ. Well, those are different situations. And I like the fact that people are now thinking, how do you incorporate all of that over time? Your platelets are activated, your anatomy is what it is, but how do you incorporate that? That brings me to my question, Mike, for you. Antiplatelets, I've always thought, and heck, you led these studies, that there's platelet activity, but there's also activation of the coagulation system.
Yeah,
and you did great work with low-dose rivaroxaban that's never really caught on.
Yeah, no, the platelets tend to calm down a bit, but what we do know is that it's a little bit like cholesterol. Some people have a higher level of thrombin generation, and that's chronic. It doesn't calm down. It may go down a little bit, and we aren't treating that. One of the first things we do when someone comes in the hospital is we give them heparin. Well, why aren't we doing something on the thrombin side chronically?
Right.
And of course, that's a whole new field that we're starting up, of factor 11 inhibition. Do I think that shot has potential to work? Yeah, because we've shown multiple times now, at least 3 times now, that inhibiting thrombin improves outcomes in coronary atherosclerosis. So yeah, I think we may see some success there.
Yeah, you and I are involved with several large trials with factor 11 inhibitor, and there are more than one factor 11 inhibitor. So I think that 2023, the cardiology world is going to see a lot of activity in factor 11, maybe a more effective anticoagulant, maybe safer anticoagulant. Jeff White talks about this decoupling of hemostatic bleeding risk from thrombotic risk. And factor 11 may be uniquely positioned.
Well, when I told my son we're going to start doing some factor 11 studies, he just kind of rolled his eyes as usual and said, Dad, why don't you stop these trials? Why don't you go look at God's randomized trial, Mendelian randomization? He literally grabbed my hand, walked me to the computer, got on the UK Biobank, and within 5 minutes showed me all the Mendelian randomization data looking at factor 11 deficiencies, like inhibition, that they were related to lower rates of having venous thrombosis events and stroke. So, there's a really good reason to think this will work. Over on the venous side, we do know that the holy grail there was met. Compared to enoxaparin, you had less venous events, yep, and you had less bleeding, both. So, we're leading about 55,000 patients plus worth of trials looking at this in stroke, AFib, ACS. The trials have been phase 2 studies, no assessment of effectiveness yet, but safety looks to be good.
Yeah, I mean, I'm excited. I think this is a new frontier in antithrombotic therapy. And again, I'm with you, Mike, that we'll continue to evolve in our understanding of the antiplatelet agents. Now I think we have an opportunity to really better understand anticoagulant therapy over the long time in some areas where really unmet need. I mean, particularly the secondary prevention of stroke data really needs some new therapies.
We really need some new therapies. We really do. And I think some of the phase 2 looked really good. I mean, yeah, we may not win on small vessel disease, but big, vessel disease and TIA, some of the phase 2 data look pretty tantalizing.
We've gone from very big sort of issues that we've observed over the last year in the cardiology world to some very specific issues around trial findings, new trials coming. I want to thank you for joining me here. My guest today has been my good friend and colleague, Mike Gibson from Boston, interventional cardiology professor at Harvard, and the CEO of the Bain Institute, a not-for-profit academic research organization. Mike, thanks for joining me on Medscape Cardiology.
See you in 2023.